Smart Talk this afternoon. When I was studying exercise physiology, I always read the textbooks that it would be nice to measure cardiac output during exercise. But that was really like some kind of holy grail in exercise physiology. Until I met actually Frank Boer last year in Rotterdam at the Erasmus University Medical Center, who actually showed us some really neat equipment that is able to actually pick up some very interesting changes of the cardiac output during exercise. Coming to Australia, I thought, well, this is something that I also have to introduce to and show the colleagues at the AIS. So I'm really happy, Frank, that you are able to come to all the way to Australia and share your experience with us. That you and your father, John Boer, who was a cardiologist, have gathered over I think the last 20 years in applying what's called signal morphology impedance cardiography. So the floor is yours, and I'm really looking forward to your talk. Thank you very much.
Should I take the microphone? Or? I got that. Okay. Well, ladies and gentlemen, thank you for having me. It's a pleasure and a privilege to be here. First of all, because it's Australia, so from France, it always looks extremely exciting and like a last frontier and everything. Also, it's very nice because you have a worldwide reputation, and it's actually a pleasure to be able to show what we did with cardiac output measurements and hemodynamic measurements in general. And so just to give you a little bit of background information, so my name is Frank Boer. I'm actually the son of Dr. Jean Boer, who signed this presentation. And we basically worked together from the inception of the entire PhysioFlow story. My father is retired now, but he was a cardiologist, a physiologist, pharmacologist, and cardiac rehab doctor. He did also a little bit of intensive care. And so the story is that in the 80s, he got very interested in non-invasive hemodynamics, and he basically acquired a device from America, and the name of the device at the time was the BOMED. And the BOMED belonged to the family of impedance cardiographs already back then. So my father was extremely excited about it. He said, oh, this is the Holy Grail. I can measure cardiac output, vascular resistance, at rest, during exercise, on heart failure patients, on COPD, or whatever kind of patients he had. So he said, this is the missing link in a lot of the diagnosis I could do. Unfortunately, like many other physicians and scientists, he got a little bit disappointed about the technology, and he found out that there were so many limitations that he could hardly use it in real clinical world. And one big limitation, as we're going to see a little bit later, was actually exercise. So he was still very enthusiastic on one side, but on the other hand, he said, there must be a solution, there must be a way to improve this technology and make it actually work as everybody intends it to work. So at the time, I was a student. I still had brains. It's a bit gone now, but anyway, he came to me and he said, Frank, I really need to help because I have this thing here, this project, I want to do this, I want to do that. So I was doing some maths and physics back then, and he said, yeah, can you help? And I said, Dad, I have no time. He said, I insist. And here I am, many years later. So it was a very incremental development, and I shall say empirical development at first. We were trying to different approaches and different ways to do it, trying to identify the limitations of impedance cardiography before we could actually proceed to the solution, which is now PhysioFlow. After a while, when I was done with my studies, we found out that it might actually be a good time to incorporate, to make it a little bit more formal, and to turn it into an R&D entity, so a company basically. And then later on, about around the year 2000, we got enough clinical data and feedback from the early users of PhysioFlow to decide that it was time to move to the next step, which was getting the device produced according to industrial standards, and also get all the regulatory work done, at least starting from Europe and then worldwide, and gradually evolve from a small R&D entity into something, actually a real company, which I have the privilege to lead. So today, by the way, my English is understandable. It's not too bad. Okay. So today it's about a device called PhysioFlow. It's a family of devices on its own. We call it signal morphology, impedance cardiography, and I will describe the methodology and then applications. So the agenda for the presentation, first off, what is it? What is this technology and how does it work? Then, of course, the next question that comes to mind is it accurate? You know, has it been compared to anything already available? Quick overview of the parameters. What does it measure? Then the applications, and I try to focus this presentation on those that are of interest to you, knowing that there's so many applications that's actually hard to follow. You know, people are now talking about neonatology, and now they want to use it in pregnant women, heart failure, coronary artery disease, pacing, critical care, emergency room. So it's like incredible. We will go through a few case studies, and then as a conclusion, a little summary of you know, the benefits of PhysioFlow and why it is different. So what is cardiac output? Obviously, you'll know it's the volume of blood pumped by the heart in 1 minute. It's a very important determinant in your oxygen transport, and of course in athletics it's essential to deliver a lot of oxygen to the tissues to make sure the athletes perform as they should. So cardiac output enters in various equilibriums. One of them is the equilibrium between vascular resistance, blood pressure, and cardiac flow. And this is mostly used in clinical. In your applications, exercise physiology, this other equilibrium is more relevant, where you have the balance between oxygen uptake, peripheral oxygen extraction, and cardiac output, and this is obviously the Fick equation. So the determinants of cardiac output, and namely stroke volume, are very simple to understand. There's preload, so volume of blood coming into the heart, which we do measure. There's contractility, so the contractile force of the heart itself. And then, of course, you pump against the wall, which is your vascular resistance, and you want to know if your vessels are stiff or not, and how much resistance do they oppose to the flow. So, now the question is, why should I measure cardiac output? As I already anticipated, there were many groups of users, intensive care, they want to see shocked patients, how they're doing. They also want to do fluid management, monitor unstable patients. Cardiologists would do heart failure, hypertensive patients. They look at the pacing optimization. Also, they use exercise tests actually to get a more sensitive detection of some pathologies, including coronary artery disease. Other applications, what is very popular now is pulmonary hypertension, and actually we do work with prominent Australian centres, one of them being St Vincent's Hospital in Sydney, and we do work in pulmonary hypertension / heart failure applications. Physiology, I'm thinking here about extreme conditions like high altitude studies, or the military also use that. And to give you an example, I was in Taiwan last week, and the Taiwanese Air Force is now using the system in the centrifuge devices to assess the jet fighter pilots. Pharmacology and toxicology, obviously you get drugs that are designed to optimize cardiac function, so it's nice to actually measure this optimization, and some drugs are actually detrimental to the heart, and I'm thinking in particular the cardiotoxicity of anti-cancer drugs, for instance. Finally, sports medicine, which is the one that is of interest here. It's in order to assess athletes, check their limiting factors, and possibly optimize training protocols in order to get the 2 or 3% that makes a difference in a competitive world. By the way, if you have any questions during the presentation, feel free to interrupt me and whatever. So, how can I measure cardiac output? So historically, the first method that had been developed is the so-called direct Fick method from the Fick equation, where you had to take actually blood samples, arterial blood samples, venous blood samples from catheters and measure the VO2. At the time it was a Douglas bag, but now there are more sophisticated approaches, of course. And the direct Fick method is still considered The best of the worst of all, meaning it's still considered, I hate to say gold standard, but probably the most accurate method available. The dye dilution technology is used a little bit for research. I think the Danish people still use it a little bit, but not so much anymore. Thermodilution has been used a lot in critical care. So you use the pulmonary artery catheter and you check a temperature dilution curve in order to assess cardiac output. These methods were very invasive, so limited applications, only very clean environments. Some of them would not work during exercise or not very well, like the thermodilution. Some clever people came with less invasive methodologies, like the post-contour analysis, where basically you piggyback on the arterial line in order to analyze the arterial waveform and give you a calculation of cardiac output. Or something that I like actually better, the transesophageal Doppler, where you put a Doppler probe directly in the esophagus. This is mostly for critical care and the operating theater. Non-invasive technologies include the indirect FIC, and I'm sure in this institution you do have experience with CO2 rebreathing or acetylene rebreathing already. The finger pulse analysis, where they use a sensor on the fingertip and they do analyze the pulse contour on the fingertip to evaluate cardiac output. This is highly questionable, but you have devices on the market. A nice Australian company called Uscom actually developed a suprasternal Doppler, where you put your probe on the suprasternal notch here and you target the ascending aorta to evaluate cardiac output. Unfortunately, it's a little bit operator dependent and very difficult to use during exercise. And the last group of devices is what is called impedance cardiography. What is impedance cardiography? So it's a very old concept. Actually, a few years ago, to my great surprise, I came across papers written in Russian language, and I could read the date only, 1941. Impedance can be used for assessing blood flow into the chest. And it's been translated to me, and I was like, wow, you know, very impressive. So they had a lot of experience in the former Soviet Union in impedance, but then it basically leaked into the West thanks to actually Eastern European scientists who work for instance, for NASA, the National Space Agency in America. And they basically applied this concept in order to do research to evaluate cardiac output measurements. So how does it work? Like, I'm sure you use bioimpedance for body composition analysis. So basically what you do, you inject an electrical current of low magnitude and high frequency through the chest, and then you have sensing electrode that pick what is called the chest impedance modulation. So from this modulation, there's one sub-signal, which is the heart impedance modulation. So there's a systolic and a diastolic flow. And from this signal, you can actually compute stroke volume, which you multiply with the heart rate you get from an ECG line to compute cardiac output bit by bit. So the history of impedance cardiography, we already went through a little bit. So in the 50s and 70s in the West, some scientists started developing it. The first industrial device was actually the one used by my father in France, this Baumet device. Then in the 90s, they did a little bit better in signal processing. In the 2000s, there was a reimbursement instituted in America, where basically the device started to be used more for clinical use. And now, of course, the latest development is PhysioFlow. So conventional impedance cardiography, I call it the volumetric approach. I'm probably the only one who calls it that way, but I think it explains a little bit how it works. So basically what the founding fathers are doing is, first of all, they take a volumetric approach of the shape of the thorax. So they need to assess the size of the thorax. So they use either a cylinder model or a truncated cone model, depends on the authors. So once they know roughly the size of the chest, they're combining with the absolute value of chest impedance. So it's the average absolute value of chest impedance, because this absolute value here is correlated to a degree to the thoracic fluid content, which you need to measure. So basically it gives you your total amount of fluid in the chest. So you need to know this baseline amount of fluid in the chest, thoracic fluid content, before you can actually analyze the pulsatile waveform bit by bit, which gives you stroke volume. To let you understand this, let's imagine you have a lake, okay? And on top of the lake, you have this wave. So what you really want to measure is the fluid in motion. So it's actually the wave on top of the lake. But in conventional ICG, you need to measure the global content of water that's actually in your lake before you can actually analyze the pulsatile waveform, which is your wave. So they do have to measure the size of the lake. They do have to evaluate the electrical resistivity of your lake, combine the two to get the total water in the lake, and then, okay, I know how much water I have in the lake globally, so I can say this is the little fraction that is actually in motion, therefore it's your wave, therefore it's your stroke volume. Do you get the concept? Okay. So, fair enough. Theoretically speaking, that was all right. A lot of people worked on it, and it was accepted as the conventional approach in ICG. Unfortunately, this is also, by itself, generating a lot of limitations. And that's what my father and myself first discovered, is basically that the limitations were related to the methodology itself. The first one, this one. Stefan, what do you think? Are you a cylinder or truncated cone? You know, in essence, it's a first approximation, but it's not the worst. The worst is actually the Z0 parameter, because this parameter is actually very temperamental. Imagine you're measuring a patient, and all of a sudden the room temperature shoots up, so the patient starts sweating, right? Nothing's changing, except that the patient is perspiring. So then the skin impedance is changing, the electrical contact with the electrode is changing, and therefore your baseline impedance is changing. Doesn't mean that your content of the lake is changing. Doesn't mean that your thoracic fluid index is changing. Also, if you have pulmonary edema, it doesn't work. Emphysema doesn't work. Overweight patients, it doesn't work because of the skin thickness, and it creates a layer of fat that's actually not very conductive. Electrode position was a problem because these methods were very sensitive to where you would place the electrode. So it means from one operator to another, you could get a completely different reading. Exercise was terrible, first because of perspiration, but second because this was extremely sensitive to motion artifact. And if you take raw impedance value during exercise, it's all over the place. So we were like, okay, it's nice because it's non-invasive, it's inexpensive, it uses just a few electrodes, but electrode placement is a problem. Only very moderate exercise, no pulmonary edema, no emphysema, no obesity, etc., etc., etc. So basically, my father said, okay, this approach is going to go nowhere. At least there's no way to improve the currently available technologies, and we do need to do something completely different. So it was actually not easy, because conceptually speaking, all the methods available were all based on impedance baseline. So how do you do impedance cardiography without impedance baseline? Well, as we are not great scientists, so we started from a very empirical approach. And the empirical approach was to have a nice black box made with the best possible signal processing at the time to get a clear and nice signal as much as possible, and also to measure all the patients my father had. And he had a lot of patients of various kinds of disease and various conditions. He was doing a lot of tilt table testing, exercise testing. He had patients, he was running a few ICU back then, small ICU, sorry, back then. So we could get a big database, and for some of the patients, we actually had an idea about the actual stroke volume because he was using Doppler ultrasound, or some of them had a thermodilution, etc., etc. So gradually, we got slowly more acquainted with the signal and trying to understand a little bit more what this pulsatile waveform actually was. And if you see these three groups of signals, so this is an ECG, derivative of ECG, so we calculate the heart rate only based on that. But if you look at an impedance waveform, you can see there's a systolic wave and a diastolic rebound. Well, this is a normal one. This is a diastolic heart failure, so this is a different waveform, and this is hyperdynamic patient, hyperkinetic patient, is also a different waveform. So then we could see that different levels of stroke volume or different disease or different postures or exercise versus rest, etc., generated different signal patterns. So that helped us understand what actually was in this signal, and of course helped us in order to extract the information we needed to extract from the signal to actually compute what we wanted, which is stroke volume. So that's why I call it the pure morphological approach. Why? Because now we don't worry about the entire lake anymore. We take a magnifying lens and we focus directly on the wave itself. So we do analyze this wave, whatever the rest is, whatever the size of the lake, whatever the electrical conductivity of the lake, doesn't matter. What matters is the shape of this waveform. And this is it's easy to understand because this waveform is actually an electrical picture of the blood flow generated by the heart. Just like a Doppler is an ultrasound picture, this is an electrical picture. So in essence, it's a very direct measurement of the blood flow generated by the heart. It's not like a pulsatile waveform taking from the periphery an arterial line or a finger pulse or whatever, or even the FIC. The FIC is just an equation based on blood samples and oxygen uptake. They call it the direct FIC, by the way, which is always a little bit strange to me, because to me it's a calculation. But here, it's a signal that is a picture of the flow. So isn't it a good idea to analyze it as actually the flow generated by the heart? So that's the idea behind the PhysioFlow. Is that understandable, the difference between the new technology and the older approach? Okay. So how does it work? I'm sure you like the stern face. Anyway, so we have 6 electrodes altogether, 2 at the base of the neck. It's not the vessels here, it's just somewhere at the base of the neck. 2 at the base of the chest. So at rest, we would do the xiphoid process area, but during exercise, it's actually better to place these 2 close to the spine at the same horizontal level, but in the back. And then an ECG derivation doesn't matter. All you need is to get a clean QRS that allows for triggering and the determination of the heart rate. What is important to remember is there's another advancement of technology that we have is it's actually this filter which we call HDZ, which is, by the way, you say Z or Z in Australia? Z, okay. So it's HDZ, high definition impedance. I had to find a name for it. The idea, it's actually a triggered adaptative filter, high performance, that stabilizes the signal very nicely. Because when we started, we could do cycloergometric exercise only, so we had a limitation with running. Thanks to this filter, now we expand the horizons and we are able to measure running subjects as well. For instance, there was a nice study that was performed on Paris marathon runners a few years ago and got published, and where you could see the micro adjustments in stroke volume are actually correlated to the micro adjustments in speed, which is interesting. So, correlations. We have a number of papers that have been published in physiology and pathology comparing PhysioFlow to other available techniques. One of them being the FIC. So that was a group of healthy subjects at rest and doing exercise. This was a very early study that was published in 2000. So back then we didn't have the sophisticated filters, but as you can see, the correlation was already quite acceptable. Also, what is very important to know is, if you talk to the critical care hemodynamic experts, what they tell you is basically they say that a cardiac output device needs to have 3 main qualities. The first, it has to provide reasonable numbers, considering the fact there is no gold standard, but they should be reasonably close to the reference methods, considering everybody has a margin of error. That's the first quality. The second quality, if nothing changes with your patient, the device should give you a stable and same number, whoever the operator is. That's very important. I call it the inter-operator reproducibility, which is critically important because some devices are very reproducible provided the same person is using it. Third, what is really important too is that if something changes with your cardiac output, the system needs to be able to pick it up. That's what I call the sensitivity. So it also has to be able to track the small changes, especially in applications like yours, where you want to gain the 3%, 5% more. It has to be sensitive in measuring differences in time. Parameters. Oh, I forgot, needless to say, everything has been evaluated with PhysioFlow. We have reproducibility studies on Ironman, test, retest at max, and the coefficient of variation between day 1 and day 3, I think, was under 4%. It was 3.8% at max. So the parameters, of course, cardiac output, cardiac index, stroke volume, etc. We also have the components of stroke volume, one of them being the contractility. We have actually a parameter which is specific to PhysioFlow called the early diastolic filling ratio, which tells you about the preload into the heart. It's not been evaluated formally or compared to anything during exercise yet. It's only at rest that we did it. After load, if you enter blood pressure into the software or automatically connected to a device like, for instance, the Tango, we give you a calculation of a systemic vascular resistance index, which is also interesting in the evaluation of the cardiovascular performance during exercise. So, quick technology overview. We have several different devices, so later on we'll perform a little live demo downstairs, so we'll be able to see it. The one that's probably the most appropriate for this application is the PhysioFlow Enduro, which is a small portable device, lightweight, about 200 grams with batteries, and it has a Bluetooth wireless transmitter that sends signal up to 100 meters in open space. You can also use it as a data logger and go run your marathon, come back and download the memory into the computer. So the battery, depending on the technology you use, lasts between 5 and 10 hours. So with this portable Enduro, you can actually use it in the lab with a good range of motion as well in the lab, or even the track and field, or do marathon studies and field studies on whichever sport is of interest. Applications in physiology, exercise physiology. So VO2 measurements have been widely used everywhere. There are some limitations. The main one being that you cannot really directly assess the heart function, or even more importantly, the arteriovenous oxygen difference. So there's this equation, which you're probably familiar with, called the Wassermann-Stringer equation, which derives cardiac output from VO2 and VO2 max. Unfortunately, this equation does work extremely well, but only on calibrated subjects, meaning healthy subjects about 28 years old. So as soon as you drift away from this optimal subject population, you cannot use the Wassermann-Stringer equation anymore, and you've got to measure cardiac output directly. So in order to assess performance, to optimize training protocols, to really get all you can get as far as information is concerned, you do have to measure cardiac output directly, and you cannot solely rely on VO2, VO2 max, or oxygen pulse. The applications in training. The one that I really like a lot is the arteriovenous oxygen difference. When you combine VO2 and PhysioFlow, you calculate AV diff. It's very interesting because it's quite often an interesting limiting factor that you can find in athletes. And also it's a factor that's actually relatively easy to play with, from what I know. It means you can actually optimize interval training protocols to work on this variable and actually increase the situation a lot as far as AV diff is concerned. Because the VO2 max, as you know, there's not much room to play, and the cardiac contractility itself is already maxed out more or less with these top athletes. So it looks like the one that gives you a little bit more flexibility is AV diff. We do believe also in the combination of what we call the stroke volume threshold, which is the level at which the stroke volume plateaus during an exercise test, and in combination with the ventilatory threshold, it's also an interesting criteria in order to fine-tune your training protocols in high endurance athletes. Basically, we think that measuring is knowing. So athletes' perception is interesting and needs to be taken into account. But it's also very nice to actually document the real physiological responses, and also document the variations of these physiological responses during, for instance, a training season. Just to give you a little screenshot of what the PhysioFlow can do for you. This is a treadmill exercise with an average calculation on 5 seconds. So every data point is 5 seconds. Here, there's an emergency stop maneuver, so the cardiac output dropped again. And as you can see on this runner, it reached over 32 liters per minute about before he recovered at a speed that's fairly high. Actually, I wrote 22 kilometers an hour, but I think it was like more, the maximal speed here was more 20 kilometers an hour. So that tells you that you can really reach high levels of exercise. Recently, your colleagues from the French National Sports Institute published a very, very interesting study in 2014 that's actually about overreaching. They took groups of triathletes and basically they did subgroups. One of them was, with a good training regimen with intensive training, but no overreaching, and the second group was clearly overreached. And they could clearly determine that in the overreached group, the cardiac performance was actually going down. So you're talking about contractility, a max cardiac index as well. So it was a nice and clean study, and actually it has a lot of potential, because this means that you can potentially evaluate the deterioration of your cardiac function during a training season as compared to the baseline at the onset of this training season. Also, this is actually a very, very interesting case on the field on a young Canadian triathlete. So she was doing a time trial in the mountains, and I'll show you a little video about this later. And she did one in the morning, this time trial here, and the exact same time trial in the afternoon. The big difference, that was about 3,000 meters elevation. The big difference is that was at cool temperature and in the shade. This was the afternoon with direct sunshine in California. As you can see, her stroke volume here was doing okay, reaching this nice plateau here. Same with the heart rate, which was fairly stable during this first time trial. You could see the second time trial, even if cardiac output was actually maintained, but in reality, stroke volume was drifting down and heart rate was overshooting as a compensation. So to me, this is really a cardiac drift related to this elevated temperature. And she said she struggled more in the afternoon as compared to the morning. She's coming from British Columbia, so living in a very cool environment, and here you're talking about over 30 degrees centigrade and even more under the direct sun. So that was actually the first time I was able to measure this cardiac drift in the field and not in the lab. So I found it pretty interesting. We did also some crazy little experiments here. This is car rally racing. So you could see the different specials here. There was no event marker. Sorry about that, because it was used as a recorder, so there was no event marker. But these are all what you call, do you call that specials in car rally racing? When they go very fast for a period of time, then they stop, then it's special, isn't it? No? Well, anyway, so they have this 5 to 6 minutes bouts where they drive like crazy, and then they move to the next spot, and then they do it again, etc., etc. So you can see the excitement here from the drive and also stroke volume response. Interestingly, between this gentleman and the lady here, there's a completely different response. He was like super calm, like an engine, ramping up and down, ramping up and down, depending. And she was all over the place, very emotional. Co-pilot. Anyway, also some interesting stuff that was done. I'm sure you recognize this device, K4B from Cosmed. So also the PhysioFlow was used in this recreational but good level marathon runners. And they did this very interesting study where basically the micro variations in stroke volume are correlated to micro variations in speed. There's some more data coming, and they're analyzing some more data about these marathon races. This is a nice case, Stefan. I'm sure you remember that one. So Stefan and I did it together in Rotterdam, one of the first time I visited. And there was a young 23 years old female athlete, and basically we did a first bout here with hypoxia, and a second in hyperoxia. And as you can see, the stroke volume kinetics was quite different between the two tests. And these were similar tests. Only the hypoxic versus hyperoxic was the only actually variable that was played on here. And that's very interesting to see a completely different response between these two tests. Would you like to comment on this, Stefan, or?
No, that's all right.
Okay. Another one that you might like, post-transplant triathlete. So it's a famous person in the Netherlands who got a heart transplant at a young age, and actually he's very famous because he's you know, part of these television campaigns to promote donations. What was very, very interesting during this exercise test is that it was actually a delayed increment in stroke volume, which means that in this case, as the innervation is not there anymore, it's only hormonal adjustments to exercise, and so there's a slow reaching of the plateau in this case, and I think this gentleman reported that it takes him a lot of time to warm up and to be like in the zone where he feels like his performance is where it should be. Another interesting situation is what I call the aging athletes, where basically, you know, they are still crazy like myself, exercising at 45, 46, trying to do things and, you know, go through their 40s and 50s like that. But anyway, you see in this case, the patient had no real risk factor for coronary artery disease. Somebody not really trained, but anyway, his ST segment was absolutely normal on the ECG. But as you can see, at this point, 120 watts, his stroke volume, instead of climbing or plateauing, dropped with a slight overshoot in heart rate as a compensatory mechanism. This kind of pattern with a change in slope in stroke volume or contractility is a clear sign that something is wrong with your heart. And generally it's coronary artery disease, but we see also similar patterns sometimes in valve disease that get worse during exercise. Sometimes shunts as well worsen during exercise, so you see similar patterns. But clearly, if you have a pattern like this, it's problematic. That being said, if the stroke volume drops in a young athlete at 180 beats per minute, you know, it's just because the filling time is too short. So it's quite normal, physiologically normal that at elevated heart rates, stroke volume drops. But in his case, the heart rate was only like about 130-ish or so. So clearly there is a problem here. So this patient was actually referred to the cath lab, so the doctor had the guts to do it, and they found that there was a small stenosis among the arteries. Another innovative tool that was initially introduced by my father, but then we tried to further spread it, and actually at St. Vincent's they're using it in Sydney. It's actually the qualitative analysis of PhysioFlow waveforms. So if you take the first mathematical derivative over time of the raw impedance waveform here, so you have a systolic waveform, which we call the S wave, a small diastolic rebound, the O wave, so it's the early diastolic rebound, and then a late diastolic bump, which is called the A wave, or the atrial kick into the ventricle. So a normal waveform is displayed here in black, so systolic, small diastolic bump, and small late diastolic bump. Gray signals shows abnormality. So the double systolic peak, I don't think you will see it anytime here. It's in case of ventricular desynchrony. Typically in heart failure patients that have ventricular desynchrony, you can see these double peaks. An elevated early diastolic wave is correlated to a fluid overload. It means that the ventricle does not cope very well with the extra fluid, and typically in congestive heart failure you may see that. But more interestingly, in the case of your athletes maybe, is this atrial waveform. In case of ventricular stiffness, you will see the A wave getting bigger and bigger and bigger to the point where it looks like it's actually merging into the S wave. It looks like the S wave starts before the QRS, and of course the systole cannot start before the QRS. It's just that this A wave becomes so big that it flows into the systolic wave. So elevated A wave correlated to ventricular stiffness, and you know, hypertrophic hearts do have ventricular stiffness and do show this A wave. And I recently sold a unit to somebody you may know, Professor Sanjay Sharma from London St. George, who is a world expert in these hypertrophic ventricles in athletes. So we do have a presence a little bit everywhere. So we have approval, product approval almost everywhere, including Australia. We are close to 600 users now in 45 countries. Some ones you may know, the Japan Institute of Sports Science, some French institutions, INSEP, for instance, Swedish Olympic Committees, etc. The device is from France, and here in Australia, it's our privilege to work with Medical Vision Australia and its representative, Adam, and they will deliver absolutely perfect service to you. So, the quick conclusion, of course, it's non-invasive is continuous. It's also very, very easy to use. It's way easier, for instance, than acetylene rebreathing because you don't require a full cooperation from your subjects. Much more freedom of breathing and freedom of motion. It's a direct measurement of stroke volume. It's not a calculation. It's based on a signal that actually is a picture, direct picture of your blood flow generated by the heart. Cost effective, we're not talking about expensive disposable, we're talking about electrodes. Also, it's not consuming a lot of time, which it is a big part of the cost effectiveness. It's only 5 minutes from the time the athlete gets in the room to the time you get your first readings. You can use it at all exercise levels and in a lot of different environments, as the little video is going to show you. And maybe it's time for a little video presentation, which is not very scientific, but a lot of fun, but at least it tells you what kind of things we can do when you want to play with the system. But before that, you might already have some questions, or a few questions. Not yet? Wow. Okay. All right, so let's play. Okay, so that was shot in California. It's just a 3-minute video.
Project Endurance, so basically 6 athletes out here, and we're learning how to improve our performance. All the years I've been able to do testing, it's never easy, and especially here in Death Valley, it's pretty wild.
They're testing us, really just kind of putting us through the paces with so many wires all over our bodies.
That's a PhysioFlow.
Really kind of seeing where performance can be taken to the next level.
It's actually 43 degrees here in Death Valley.
Goal here, is to make our athletes perform better.
We hope to find how these different conditions impact the ability of the heart to generate blood flow.
Basically, we are human guinea pigs.
I mean, this is essentially the lab. It's got all the storage facilities and things, and we can explore it in different ways.
It's not easy with dozens of different technologies being utilized at the same time. What can we tweak? What can we change so that they are recovering better, optimal?
Being hooked up to the stuff is new to me. I mean, I've never done body testing like this. It's pretty wild.
I want to learn a little bit more about my body and how my heart works and how my lungs work.
Red Bull has brought us all in together to try and brainstorm and develop performance protocols that are going to lead to the athletes being more successful in what they do.
Today we are on top of Sierra View, elevation about 9,500 feet, and we're doing some testing to answer the question, why do we get tired? Why do we fatigue? Why do we quit? What limits our performance as human beings?
Good job, good job.
She's the triathlete that drifted.
Technology infiltration all in one shot. I'm going to have it all together. It's pretty spectacular.
Good job. All right, done. Nice.
Once we get the data back again, it'll be interesting to see whether I really did better at 9,000. I kind of felt better up here. I don't ever want to go back to Death Valley again.
The hardest thing I did this week was the time trial, or even the second time trial that they surprised us with.
Part of the main theme of the camp is the idea that the brain regulates how we perform when we exercise. So we've set up a time trial course up the canyon here. They have no idea how far they're riding. They don't know this yet, but an hour later they're going to repeat the time trial.
It's actually a couple of hours.
They didn't tell us what we were going to do. They didn't tell us how long it was, or that we were doing the time trial twice. We thought it was one.
Don't surround your
start exercising, within a few minutes we're seeing changes in performance. So clearly the brain is doing something to alter the performance that we see when we go to that altitude.
You know, I think knowledge is power. Even the smallest detail can get you an extra 0.5%, and a lot of times that's the difference between winning and losing.
I learned a lot about when to eat, how to eat, while I do my competition. Nobody's ever done testing like this before. It was just an amazing experience.
I think that it's going to take a while to really do a proper assessment. We're still at the phase of downloading data and looking at the individual technologies, but we really want to come together and kind of overlay the technologies and the information that we got so we can see what we really learned.
Red Bull is seriously interested in giving athletes the tools they need to be as successful as possible.
Okay, there's obviously a marketing component to this because that's what Red Bull does. However, it was interesting to play actually with the different technologies and push the limits a little bit, see what we could observe. One difficulty I found during this camp over there is that they were playing with way too many variables at the same time. So at the end of the day, it was kind of difficult to interpret data because we were seeing things. But then, you know, what is it? Is it the temperature? Is it the elevation? Is it because it was repeat testing? You know, we didn't really know. However, it was a wonderful experience that actually we do repeat every year with different focus. So I went there in May again, and it's pretty good. Thank you.
Well, thank you very much, Frank, for this teaching on cardiovascular medicine and physiology. I'm sure there must be some questions in the audience. Who would like to ask the first question to Frank? Now he's here with all his experience.
Good question. Frank, how does it measure the? How do you quantify the? Sorry, how do you quantify the contractility?
The contractility, we do use a surrogate for it, which is the maximal velocity of the flow that comes out of ventricle. You know, we have this signal, the DZ of a DZ of a DT max, which is actually the first mathematical derivative of a time of your impedance, raw impedance waveform. So it's your rate of change. So the peak of this signal tells you about the velocity of the flow, which we think is directly connected to the contractility.
And so that's contractility overall. You can't. It doesn't look at right versus left-sided.
Yeah, it's overall, but we know that the velocity is overwhelmingly generated by the left ventricle compared to the right ventricle. So there is a little bit of a right ventricular component to it, but most of the components we see in this signal are actually aortic components, left ventricular components and aortic components. As a matter of fact, we have a separate piece of software that reanalyzes waveforms, but will be soon integrated in the main software, where basically we use PhysioFlow signals to assess the aortic compliance.
Any of the doctors who would like to ask a question? No. I think we've discussed it before, Frank. Do you think it makes sense to measure electromechanical delay if you compare the electrical signal of the heart with the ICG signal?
Is that it's the Weissler index, right? The old Weissler index that was developed in 1962. It does. What we see is that the electromechanical delay is related to the shape of the heart, basically. And typically in a heart failure, it's much longer than in normal subjects. I have no idea how to use it specifically in athletics, to be honest.
Well, one of the other holy grails, of course, is to predict cardiac arrhythmia in athletes. So if there is fibrosis in the heart, you might expect that could actually affect your EMD as well. But of course, there's no, I mean, it would be a new research project. But I was wondering if you can actually, does your software provide this kind of numbers?
Yeah, I'll show you. It actually doesn't provide the number, but you can easily calculate or assess it. So if I open a recorded measurement, there's actually one I'd like to show you if we have a little bit of time. I measured the subject recently. But anyway, if you go to the calibration signals, so you display average signals here. Let me magnify this a little bit. You all see okay? So what you can do is to focus on the R wave here and then measure the time interval between the R wave and the peak here, which in this case is about 140 milliseconds, so between here and here. Mm-hmm. So this is your electromechanical delay. Mm-hmm. As you can see, it's fairly easy to use these calipers to assess it. It's not automatic, but maybe we could make it an automatic parameter someday. Okay. It is actually calculated by the device, but not displayed, but don't tell anybody. Okay.
All right. Anyone else who would like to ask Frank a question? Because otherwise I invite you for a live demo at the Physiology Lab. It starts at around 2:30. We have a subject who's going to be rowing, cycling, and running, and you can see how your signal looks like under these different conditions. Because I think I'm pretty excited in having discovered this holy grail that I was looking for when I was studying exercise physiology, and I would be really excited if we can get this type of technology, use it for the athlete's health here at the AIS. So yeah, so once more, thanks a lot for coming over and giving a wonderful presentation. I think
Thank you for having me. It was a great pleasure.